A 36-year-old woman presented to her primary care physician with complaints of persistent fatigue, weakness and frequent headaches over the past 6 months. She also reported feeling short of breath during her usual activities and experiencing palpitations. Her medical history was notable for iron deficiency anemia diagnosed a year ago, for which she had been taking oral iron supplements without significant improvement in her symptoms or laboratory values. She mentioned that her menstruation was regular, with no issues of heavy bleeding or abnormal periods. Despite adherence to her iron supplementation regimen and a diet rich in iron, her recent blood tests revealed a hemoglobin level of 9 grams per deciliter, mean corpuscular volume of 70 femtoliters, and ferritin level of 8 nanograms per milliliter, indicating refractory iron deficiency anemia. The primary care physician continued to prescribe oral iron supplements, attributing the lack of improvement to poor dietary absorption without further investigation into the underlying causes. The diagnostic error in this case involves the failure to consider and investigate secondary causes of refractory iron deficiency anemia, leading to prolonged symptoms and ineffective treatment. 1. Symptom persistence. Despite continuous oral iron supplementation, the patient's anemia and symptoms persisted, indicating a need for further investigation beyond dietary iron intake and compliance. Despite continuous oral iron supplementation, the patient's anemia and symptoms persisted, indicating a need for further investigation beyond dietary iron intake and compliance. The primary care physician did not consider or evaluate for underlying conditions that could cause refractory iron deficiency anemia, such as celiac disease, atrophic gastritis, Helicobacter pylori infection, and potential sources of gastrointestinal bleeding, which are critical to identify in such cases. The regularity of her menstruation ruled out menstrual blood loss as a primary cause. The following diagnostic steps were initially missed. Positive tissue transglutaminase antibodies, or TGIGA, were not checked initially, delaying the diagnosis of celiac disease. When eventually tested, the results were positive, and subsequent endoscopy confirmed the diagnosis with villous atrophy in the small intestine. An upper endoscopy to assess for atrophic gastritis or Helicobacter pylori infection was not performed initially. Later, biopsies revealed chronic atrophic gastritis, but were negative for Helicobacter pylori. To rule out gastrointestinal sources of blood loss, such as polyps, ulcers or malignancies, a colonoscopy was necessary but not performed initially. When conducted later, the colonoscopy revealed several benign polyps but no significant bleeding source. Testing for TMPRSS. 6 mutations to rule out refractory iron deficiency anemia, or IRIDA, was not considered initially. When tested, results were negative, ruling out IRIDA. Conditions such as chronic kidney disease, autoimmune disorders, and chronic infections were not explored early on. Early serologic testing for celiac disease, gastroscopy, colonoscopy, and genetic testing for IRIDA should have been performed given the refractory nature of her anemia. By failing to thoroughly investigate and address the underlying causes of the patient's refractory iron deficiency anemia, including the need for a colonoscopy, the primary care physician missed critical diagnoses, resulting in prolonged ineffective treatment and persistent symptoms. This case underscores the importance of a comprehensive diagnostic approach in patients with refractory iron deficiency anemia.